Now, there is a sort of special type of medical study called a cost-effectiveness study where we really try to figure out not just if something works, but if it's worth it. And that's what we're going to talk about here. We're going to discuss cost-effectiveness studies and how to interpret them, talk about the value of 1 year of a human life. We are going to talk about a quality-adjusted life year and what the heck that means, and remind you that cost-effectiveness is not really about putting dollars on human lives, but on deciding where these dollars go. All right, so to figure this out first, I want you to imagine with me that you're in the market for a new television. You're at your local electronics store, checking out the new TVs. You're a simple person. All you really care about is screen size and price. This should be pretty easy. The first TV you look at has a 30-inch screen and costs $300. Seems pretty good. But next to that, you spy a 40-incher for the low price of $400. You make your decision. You're going to buy the 40-inch TV. But just as you're wheeling it towards the cashier, you spy another option, a 39-inch TV for $310. By Grabthar's hammer, what a savings. Sure, you'll never do better than this. You race towards the checkout, only to spy the final price, a 50-inch TV for $300. This decision just became a no-brainer. Aside from this electronics store clearly having no idea how to price televisions, the decisions you just made really inform the major points of cost-effectiveness studies. So let's put this on a graph here and just sort of walk through it. So we started at a 30-inch screen and $300, and that was acceptable to you. But then I presented you an alternative. I said, what about a 40-inch screen that costs $400? And you said, sure. I'm willing to pay the extra $100 for an extra 10 inches of screen real estate, so to speak. That was worth it to me. But then I threw in this wrinkle, which was this TV that was not quite 40 inches, not quite as good in terms of size, but way, way cheaper, $310 versus $400. And all of a sudden, that $400 TV is not acceptable anymore. So despite the fact that you would have taken that TV, the existence of this other TV makes you change your mind, which is kind of strange, right? Like the fact that that other TV exists makes this TV unacceptable. So that's an interesting first point here. And then, of course, we have our final point where we had this big TV that was just as cheap as the little TV, and there's just no reason you wouldn't pick the big TV. Remember, I just told you that screen size and price was all that mattered to you. So there are a couple of key concepts here that you can glean. One is called the incremental cost effectiveness. The incremental cost effectiveness is not that overall price, the overall screen size per dollar calculation that you could do for any TV. The incremental cost effectiveness is how much it costs you to move up, right? To get that one extra inch. And that is often what dictates people's decisions, okay? So you're not looking at the raw value of a given TV. You're looking at the incremental value between it and the closest other choice. That's the incremental cost effectiveness ratio. The other concept you want to be aware of is what's called a dominant strategy. In this example, the dominant strategy is the huge TV, the 50-inch TV for $300. It is just as cheap as the smaller TV. You get more bang for your buck. There is no reason you wouldn't choose this TV. So when there is a dominant strategy, for instance, in medicine, it means that a treatment works better and is cheaper than the existing treatment. There's literally no reason that you wouldn't pick this treatment. As you might imagine, we rarely find dominant strategies in medicine. So just to hammer home the incremental cost effectiveness ratio a little bit, again, the price per inch is not really the key here, right? We could have calculated the price per inch for every TV. That is not what matters. What matters is the additional price per additional inch as you're marching down the aisle of TV size. This is the incremental cost effectiveness ratio. In general, we're willing to pay more to get more, but not ad infinitum, right? We're not going to always be willing to pay any price to get a small benefit. And the presence of alternatives along the way can change the choices you make. And that's really interesting because that means when new medications come along, we often have to reevaluate the cost effectiveness of all the other medications that we had, even the ones we'd been using already and had decided were cost effective. we now might have a new option that changes that calculation. Pretty fascinating in my opinion. So here's an example of a study. This is looking at sofosbuvir. This is by any definition, a breakthrough medication for hepatitis C treatment. Hepatitis C, prior to the development of this class of agents, was often a chronic disease, often resulted in cirrhosis, cancer, and death. The treatment prior to the emergence of these drugs worked in about 20% of people, not very effective, had a lot of side effects, but was cheap, so that's nice. And then these drugs came along, and we're seeing cure rates of about 98, 99%. I mean, clearly superior in terms of effectiveness. The screen size is clearly bigger on this TV, but man, do they cost more. So these drugs cost potentially hundreds of thousands of dollars per year. Very expensive drugs. Okay, how do we decide if they're worth it? Well, you need to decide what your willingness to pay is, okay? I will tell you right up front that these drugs are not dominant, okay? So the drug doesn't cost less and work better. That's easy and everyone can go home. No, it's not dominant. We have to make a decision. When you're making a decision, you can ask, okay, well, how much am I willing to pay for the benefit that is seen? And this graph is a little bit busy, but I just want you to focus on the green line. The green line represents patients who have cirrhosis from hepatitis C but haven't received treatment yet. It's the most common person you might treat with this drug versus the older drug that doesn't work very well. And what it says here is, as you can see, if you're willing to pay $0, $0 extra, well, then no, this is not cost effective. We cannot give you the bigger TV for free. I'm sorry, sir. So this is not a dominant strategy. As you're willing to pay more, you can see that the chance that this is the cost-effective thing to do goes up quite dramatically, and you start getting to high numbers around $50,000 per patient or so. Now, how much is that? What does that mean? Like, how can we assign a value to human life? Well, I'll walk you through that in just a second. I remember sort of an old Simpsons quote where the guy says, maybe we can find this clip where there's a salesman and he says, you know, surely you can't put a price on your family's happiness. And Homer says,
I wouldn't have thought so either, but here we are.
When we're talking about paying for something, we have to ask who's paying. And every cost effectiveness study is going to give you something they call the perspective. So we did this analysis from the perspective of the patient, or from the perspective of the insurer, or from the perspective of Medicare. What do they mean? Well, they're looking at the costs that, for instance, the patient incurs, which means that they're taking into account the fact that, well, you know, maybe insurance is covering some and the patient is covering others and things like that, right? So the calculation actually is going to change a little bit depending on what the perspective is. So pay attention to that. The willingness to pay often differs a little bit as well, right? Like a patient may be willing to pay more to help themselves than they are to help someone else or society at large. The insurer may not be as willing to pay, even if it increases costs on the patient, okay? And then a lot of studies will try their best to use what they call a societal perspective. These are studies which try to integrate every cost. So not just the patient, not just the insurer, but the cost of, you know, missed days of work and things like that this disease incurs. So it's really trying to get at, like, as a society, should we pay for this new treatment or not? Can make a big difference in whether something is deemed cost effective or not. So look for the perspective. Now, what's a life worth? Well, we should all kind of have an intuition that not all years of life are equal. Like some years of your life are really great and some aren't. You don't often know beforehand which is which. But how do we quantify this? And like, how do we say, you know, what, based on how you're feeling now, how much is this year of your life worth? There's basically two methods that they do this, and this is kind of a fun thought experiment for yourself. So one is called time trade-off, and it says, how many years would you give up to be in perfect health until you die? So I am currently 38 years old, and if someone asked me this, they'd say, like, how many, you know, you're going to live to whenever you're going to live, how many years would you like to shave off that, but I'm guaranteeing you perfect health until the day you die? Well, I am healthy now, fortunately, knock on wood, so So I would probably say, no, I'm good. Like, I want to live as long as I want to live. I'm not willing to shave off many years. But if I were in constant pain and severely debilitated and someone said, I'm going to restore you to perfect health, you're going to be in perfect health until the day you die, how many years of less life is that worth to you? I might say, I would take off 5 years or something. And that implies how much value I'm putting on my current state of health relative to my life. Interesting concept. The other one is called a standard gamble, and this is also a fun thought experiment. There's a treatment that will either restore you to perfect health or kill you. What odds would make you willing to take that treatment? Okay, so I've got this pill, and it's either going to kill you or restore you to perfect health. Now, for me to take that pill, I'm already in perfect health, more or less. I mean, I guess I could be a little bit better, but maybe if it made me really strong and handsome. But right, like, how much risk am I willing to take? Well, for me personally, I'd be like, oh my God, not much. Maybe if there's 1 in a million chance that it would kill me, or 1 in a billion chance that it would kill me, I'd say, all right, I'll take it to get strong and handsome. But for someone who's in chronic pain or has cancer or something like that, they might be willing to assume some substantial risk. They might say, you know what, I'll take a 1 in 10 chance of being dead in order to restore myself, to have 90% chance to restore myself to perfect health. That says that maybe right now your life is only worth 90% to you, what it would be worth otherwise. All right, so it's a little uncomfortable to talk about, but this is how we define what life is worth. So let's put some numbers to it. What the heck is a QALY? So you'll hear QALY. QALY is a quality adjusted life year. It recognizes the fact that, just as we explained, not every life year is worth the same amount to a given person. So 3 quality adjusted life years is equivalent to 3 years of perfect health or 6 years of like 50% health. Okay? In the US, many economists think a full QALY, 1 year of perfect health, is worth somewhere between $50,000 to $100,000. You can more than feel free to disagree with that, but the reason we put these thresholds on it is, here's the secret, like, we don't have infinite money and infinite health resources. So if we can say this treatment is going to give this guy 1 year, 1 QALY, but it costs $1 billion, as a society we may just say, I'm sorry, like, we can't do that for everyone. So you do need to put thresholds on things. I'm not saying I know what the threshold is. Economists say your life is worth about $100,000 a year. Here are some of the costs in medicine, just to give you a sense per QALY. So like the annual pap smear for women, about $31,000. Now remember, this is the cost to society. So the practice of doing a pap smear it costs $31,000 to gain those life years. Now, those life years are gained in women who otherwise would have developed cervical cancer. This is not, every person is not getting charged $31,000. We actually would say that's pretty good. That's a pretty good medical intervention. It's okay to spend your money that way. Whereas amoxicillin for bronchitis, okay, from a societal perspective, is incredibly expensive. It doesn't really save any life years or even quality adjusted life years, because bronchitis is just not that bad and you kind of get through it. And it's expensive and there are complications because you can get resistant bacteria and stuff like that. So you might decide as a society that, we just shouldn't do this. It's too expensive. It's too costly. Those decisions are fortunately not up to me. So our take-home points for cost-effectiveness studies. Cost-effectiveness studies are about choices. Don't get hung up on the dollar amount. Think about it more like, should we spend what limited money we have on this or that? You could make an argument, we should just spend it on the cheapest thing that gets us a quality-adjusted life year, but again, not my decision. They're about margins. It's not how much you're willing to pay, but how much extra you're willing to pay, right? That incremental cost-effectiveness ratio is crucial. A year of life may be more or less valuable depending on the quality of life. That should make intuitive sense. Who is paying and how much they're willing to pay may change the ultimate decision. A societal perspective is very powerful, but pretty hard to figure out all the costs. Thanks a lot.